Good morning, USRNs. Today we will talk about the endocrine system and its disorder. Pag-uusapan natin dito ang antidiuretic hormone disorders. We have diabetes insipidus, SIDH or SIAD, Addison's disease. We will also talk about pheochromocytoma, hypothyroidism versus hyperthyroidism, very common in NCLEX. And also we will talk about pituitary gland problem. We have the hypopituitarism and hyperpituitarism and insulin therapy. Now this could be a very long discussion, so I will create another video for the in-depth of other endocrine diseases or illnesses. Thank you. Alright, so first we will talk about the endocrine system. The purpose of endocrine system is to manage the hormonal release. It also maintains equilibrium or balance and sustain proper organ function. So there are two hormones of endocrine system. We have the anterior hormone, which covers 80% of the pituitary gland, and the posterior hormones, which covers 20% of the pituitary gland. The hormones are being regulated by our master gland, which is the pituitary gland. So those are the two lobes, the anterior lobe and the posterior lobe. Example for the anterior lobe, which is 80%, A for undaming hormones. We have the growth hormone, thyroid stimulating hormone, melanocyte stimulating hormone, luteinizing hormone, adrenocorticotropic hormone, which handles stress. We have the prolactin, fluid or follicle stimulating hormone, parathyroid hormone, and the melatonin. For the posterior, we only have two, which is the antidiuretic hormone or ADH and the oxytocin. Alright, we'll talk about the disorders of endocrine system. Specifically to antidiuretic hormone, we have the problem diabetes insipidus. The cause of diabetes insipidus is autoimmune. It could also be surgery. The pathophysiology of this illness is that there should be a cause. So that's the cause of it, autoimmune or surgery. And the causes will lead to polyuria. Polyuria meaning there is more than 30 cc per hour or like 5 to 6 liters per day of urine. Polyuria will lead to increased serum osmolality. That will lead to urine specific gravity that is decreased. The normal level of specific urine gravity is 1.010 to 1.030. Polyuria will also lead to hypernatremia. That will lead to hypokalemia. That will lead to prominent Q wave or dysrhythmia, which is an emergency. Polyuria will also lead to dehydration or fluid volume deficit, which increases hematocrit or hemo concentration. The signs and symptoms of dehydration are flattened neck vein, weight loss, decreased central venous pressure, sunken fontanelles, and sunken eyeballs. And this may lead to shock. Signs and symptoms of shock, we have hypotension, tachycardia, tachypnea, hypothermia, and narrowed pulses. Hypo, tachy, narrow. So, imagine nyo na lang na merong isang crack na baso. The water flows out in it in a form of sodium. So, sa taas water, sa baba salt. Then the glass is cracked, the water flows out, and it will increase in sodium kasi nga lutang si water sa taas kay salt. Okay, The management for diabetes insipidus would be to prevent urination. That's going to be the main goal here. We can give out medication to the patient like Pressines. In order for you not to forget about Pressine, it sounds like press it in to prevent urination. The example drugs of Pressines would be vasopressines and desmopressin. The route for the medication would be intranasal. And when you do it, or when you administer those drugs via intranasal, do not directly point the tip to the nostril. You need to point it at the sides. You need to watch out for circulatory overload. Circulatory overload, which is a sign of fluid volume excess. Other management for diabetes insipidus would be fluids, either or isotonic and or hypotonic. Diet should be low in salt. You need to give high potassium food. We have the PABOs and monitor intake and output. Since this is autoimmune, we can also give out corticosteroids, those drugs that has SON at the end of the name. So the food that has high in potassium would be the PABOs. That's potato, avocado, banana, oranges, watermelon, and strawberry. All right, the second complication of the disease process for antidiuretic hormone would be SIAD, or the syndrome of inappropriate antidiuretic hormone. The cause of this is autoimmune, and also the other cause would be the small cell carcinoma from lung cancer. So this will lead to increase in ADH. That will lead to oliguria. Oliguria naman kulang sa ihi. That will cause decreased osmolality, and inversely proportional, there will be an increase with urine specific gravity. Oliguria may also result to hyponatremia. Hyponatremia will lead to hyperkalemia or tall peaked T wave. Hyponatremia will lead to delusional hyponatremia, which will cause neurologic manifestation to the patient. That will lead to seizure. Seizure will lead to increased intracranial pressure that will lead to coma. Oliguria will also go farther to fluid volume excess. So there will be decreased hematocrit, which is hemodilution, and will lead to edema, or fluid volume excess will lead to edema. Signs and symptoms of edema would be distended neck vein, bulging fontanelle, periorbital edema, weight gain, congestion. That will lead to cerebral edema in brain, pulmonary edema in the lungs, and cardiac tamponade, which is an emergency or congestive heart failure if it goes to the heart. The management for SIAD would be to promote urination, and the drug of choice would be demiclocyclines. This is also an antibiotic. The side effect would be diuretic. So it's an antibiotic given for SIADH in order to promote diuretics. Other medication would be diuretics, example potassium wasting diuretics. We have mannitol, Lasix, Bumex, and hydrochlorothiazide. Other management for SIADH would be fluid hypertonic solution due to congestion and edema. It has dextrose and glucose content. Glucose has diuretic effect. When it comes to diet, diet should be high in sodium and low in potassium. We need to monitor weight of the patient because weight is the sensitive indicator of fluid imbalance, and monitor intake or input and output. Monitor level of consciousness and give corticosteroids because this is an autoimmune disease. So ang nangyayari sa SIADH, there is more water. Let's say there is a glass of water and salt at the bottom. There is more water being added. So, ang salt nalulusaw ng water. That's the reason why we need to give high sodium diet to patients having SIADH. Alright, the next disease that we will talk about is the Addison's disease. Addison's disease is very common in NCLEX. It's caused by autoimmune, so there will be an adrenal gland decrease. The adrenal gland, we have two parts right there, the cortex and the medulla. They will both decrease. The cortex, we have under cortex the cortisol and mineral corticoids. Both of them will also decrease. If there is a decrease in cortisol, patient will have an inability to handle stress. The patient will also have hypoglycemia. If there will be a decrease in mineral corticoids under cortex, the patient will have dehydration. That will lead to fluid volume deficit. That will lead to shock. The patient will also have hyponatremia, hyperkalemia, and tall peaked T wave. On the other hand, we have on the medulla, where catecholamines are, they will also both decrease. So the catecholamines, we have both epinephrine and norepinephrine there. Epinephrine increases because it needs to compensate, but the norepinephrine will decrease. If there will be an increase in epinephrine, there will be an increase in heart regulation, there will be tachycardia, and there will be tachypnea. That will lead to shock. While the norepinephrine, on the other hand, which also decreases, there will be a decrease in blood pressure regulation and hypotension. That will also lead to shock. So pag napansin nyo, lahat ng signs ni adrenal gland, they all decrease except for the epinephrine. And also meron din siyang hyperkalemia. So see, Addison disease, everything that you have seen here that decreases, kabaliktaran naman yan, I see Cushing syndrome, which is everything going up. Okay? The management for Addison's disease and Cushing and Addison would be corticosteroids. Ito yung may mga zones, si prednisone, dexamethasone, betamethasone, methylprednisolone. And remember, when giving out corticosteroid, take it with meals because this is GI irritant. It also causes osteoporosis for long use. There will be risk for rupture. Patient will be risk for hyperglycemia also. You need to do annual eye check because patient will be at risk for cataracts. It also decreases immune system because of the process of agranulocytosis infection. So the signs and symptoms would be fever and sore throat. A special management for Cushing, due to high function of adrenal gland, patient will have adrenalectomy or removal of the adrenal glands. Watch out for Addisonian crisis. Addisonian crisis will lead to risk of infection and shock. Management, you need to report to primary health care physician. Now we will talk about pheochromocytoma. Pathophysiology: the tumor attacks adrenal gland and adrenal gland. Under adrenal gland, we have cortex and medulla. Everything in cortex is normal. Cortisol, glucocorticoid, and mineralocorticoid. However, in the medulla, there is an increase in function. So there will also be an increase in catecholamines. There will be an increase in epinephrine. So that will lead to tachycardia and tachypnea. There will also be an increase in norepinephrine. So there will be hypertension. And both epinephrine and norepinephrine will lead to hypertensive crisis. This is an emergency. Patient will be risk for stroke or cardiac arrest. Management for pheochromocytoma would be no palpation on the abdomen, no heating pads as well on the abdomen because this stimulates adrenal problems. Medication would be hydralazine and sodium nitroprusside. This is for antihypertensive crisis meds. This is an emergency drug. Surgery, we have adrenalectomy due to the tumor. Watch out for Addisonian crisis. Signs and symptoms of Addisonian crisis would be shock, altered level of consciousness, and coma. And for Addisonian crisis management, because this is autoimmune, we can give corticosteroids and you need to report to healthcare provider. Okay, pagdating naman sa thyroid stimulating hormone, meron tayong dalawang problema dyan. We have hypothyroidism or myxedema. Meron tayong hyperthyroidism or Graves' disease. Sa hypothyroidism, there is a decrease in vital signs. There is no metabolism for hypothyroidism. Everything is going down mostly. Aside from decreased vital signs, patient will also feel lethargic or brain fog, weight gain, dry skin, cold intolerance, menstruation problems, hair growth problems, constipation, oliguria, increased cholesterol due to decreased sedimentary lifestyle, or increased cholesterol buildup in the arteries or atherosclerosis. Management for thyroid stimulating or management for hypothyroidism would be low caloric diet, high fiber diet, anti-hyperlipidemic, and the drug of choice would be HMG, CoA inhibitor, hydroxy-3-methylglutaryl coenzyme A reductase inhibitor. Hyperthyroidism, on the other hand, or Graves' disease, there is fast metabolism, opposite of hypothyroidism. It has increased vital signs. Patient is alert and irritable. Patient is having weight loss. Patient is having moist skin. Patient is having heat intolerance. Patient will also have menstruation problems. Patient will have hair growth problems. Dito yung hair niya is manipis. Patient will have diarrhea, polyuria, and increased reduction of aqueous humor. That will lead to fluid retention in the eye and muscles. That will lead to eye muscles. That will lead to exophthalmos. Management would be high caloric diet, increase in oral fluid intake, eat bulk forming foods. Medication is antidiarrheal, Diatabs, loperamide. Alright, let's continue. The drug of choice for hypothyroidism would be levothyroxine or Synthroid. Tips to remember: it should be given before breakfast and it should be given at the same time of the day. If in any case you miss to give levo for or to the patient on that day, you need to skip it and give it the next day. This is okay for pregnant women. It may cause cretinism, so we need to prevent cretinism. And this could be a prevention for cretinism. The opposite of cretinism would be alcohol fetal syndrome. The hallmark sign of alcohol fetal syndrome would be philtrum. Other management for thyroidism, we have RIO or radioactive iodine uptake. This is an NCLEX favorite. The purpose of RIO is to destroy thyroid gland by radiation. Note, the maximum time for the nurse to be exposed to the patient with RIO is 30 minutes per shift. The nurse should wear a dosimeter badge. Tips to remember: avoid exposure to pregnant women when taking RIO, and also to children. It weakens the immune system. There will be a risk of infection. There will be fever and sore throat. Flush the toilet 2 to 3 times after use. Use bleach to clean the toilet. Separate soiled clothing of this patient. You need to isolate the patient. No breastfeeding, and don't accept visitors within 48 hours. The second other management of thyroidism would be thyroidectomy. This is the removal of thyroid gland. The thyroid gland is located in the neck area. This is highly vascularized area. So patient is going to be prone for bleeding. Tips to remember: use Lugol solution to decrease vascularization. Lugol contains high content of iodine. You need to watch out for allergy to iodine. Avoid shellfish, oyster, shrimp, and betadine. Post-op position, post-thyroidectomy should be semi-Fowler's position. For hyperthyroidism, the drug of choice would be propylthiouracil or PTU. Example would be tapazole. Tips to remember for tapazole is that it should be taken before breakfast or before lunch. This is not allowed to pregnancy. This may cause for exophthalmos in hyperthyroidism, we need to give artificial tears and eye patch to the patient, and also paper tape bedtime. The management for exophthalmos, we have the mnemonic STAR. We can give sunglasses to the patient, tape the eye at bedtime, artificial tear, methyl cellulose, and reinforced smoking cessation. Alright, so continuation with thyroidectomy. The complication of thyroidectomy would be risk for bleeding, infection, and parathyroid gland can also be removed, resulting to hypocalcemia. That will lead to tetany. Signs and symptoms of tetany would be Chvostek sign, Trousseau's sign, and laryngospasm or stridor. This is going to be the cause of death. Laryngospasm is an emergency. Complications of thyroid problems. We have mixed edema coma. This is a severe form of hypothyroidism. There is an extreme low of metabolism. The patient will have seizure, shock, hypoglycemia. The management is to report to healthcare provider. Complication for thyroid problem, another one is hyperthyroidism. Thyroid storm, which is a severe form of hyperthy, extreme high metabolism. So mixed edema is extreme low, hyperthyroidism, the complication is too high metabolism. The signs and symptoms would be there is an increase in blood pressure, which is a hypertension crisis or hypertensive crisis. There will be chest pain due to fast respiratory rate that will lead to cardiac arrest. Severe hyperthermia will also be one of the signs and symptoms, and there will be a febrile seizure. It'll increase the intracranial pressure that will lead to coma. And this is an emergency and needs to be reported to the doctor. That's going to be the management for thyroid storm. NCLEX hot topic, actual NCLEX question, how to check the bleeding. For post-thyroidectomy, you need to check on the nape of the patient. Okay, so we will move to the next topic, that would be pituitary gland problem. Yung gagawin natin dito kasi included dito sa discussion supposedly si insulin therapy, pero I decided na i-move na lang siya sa next video kasi medyo mahaba-haba na to. Isama ko siya sa diabetes mellitus. So, pituitary gland problem, we have hypopituitarism. There is a decrease of function of pituitary gland. The causes is autoimmune, Sheehan syndrome, which is a decrease of pituitary gland function after pregnancy. Signs and symptoms nito, bababa lahat si ADH, si TSH, si ACTH, and si GH. No, lahat ng hormones na yan bababa. Si ADH or si antidiuretic hormone, si thyroid stimulating hormone, si ACTH or adrenocorticotropic hormone, and si growth hormone. So anong effect kapag bababa yung mga hormones na yan? Kapag bababa si antidiuretic hormone, that will cause diabetes insipidus. Kapag bumababa naman si thyroid stimulating hormone, that will cause mixed edema. Kapag mababa si adrenocorticotropic hormone, that will lead to Addison disease. Kapag mababa naman si growth hormone, that will lead to dwarfism. Medication for dwarfism, we have somatotropin. It should be given before puberty. The route is subcutaneous. Mode of action, it increases growth hormone. Risk factor for dwarfism would be hereditary. Complication for dwarfism would be mental retardation. Okay, sa signs and symptoms ni hypopituitarism, dahil bumaba yung mga hormones na yon, patient will be at risk for shock. Si hyperpituitarism naman, it's opposite with hypopituitarism, obviously. All of the said hormones, ADH, TSH, ACTH, growth hormone, tataas siya. So kapag tataas si ADH hormone, that will be SIAD, which is opposite of diabetes insipidus. Kapag tataas naman si thyroid stimulating hormone, that will be hyperthyroidism or Graves' disease, opposite kay mixed edema. Kapag tataas naman si ACTH, magkakaroon siya ng Cushing disease, that will be the opposite of Addison's disease. And kapag tataas naman si growth hormone, magkakaroon naman siya ng gigantism. By the way, gigantism and acromegaly are different, two different things. If before closure of the epithelial plate, that will lead to gigantism. Pero after closure of epithelial plate, that will be acromegaly. Epithelial plate is thin layer of cartilage that lies between the epiphysis and metaphysis. Hyperpituitarism or hyperpituitarism management is bitemporal hemianopsia, loss of peripheral vision, and needs to be reported to the doctor. Oh, by the way, worst acromegaly is S3 and S4. Magkakaroon siya ng S3 and S4. Watch out for S3 and S4 heart sounds. Ibig sabihin ng S3 sounds, those are the ventricular sounds or the gallop sounds. Parang horse sound, no? Horse 3, horse 3, horse 3, horse 3, horse, S3. Extra dub after S2. Yan yung S3. Si S4 naman, that's atrial gallops. Horse then, extra sound after S1 naman. S3 after S2, S4 is after S1. S3 after S2, S4 is after S1. Lub dub, or I mean lub dub, lub dub. The drug of choice for hyperpituitarism would be sandostatin. Sandostatin. Management, surgical management would be transsphenoidal hypophysectomy. Transsphenoidal hypophysectomy. The site is between the upper lip and the upper gum. Post-op, you need to avoid Valsalva maneuver to the patient after hyperpituitarism or after the surgery of transsphenoidal hyperresectomy. Avoid straining also, avoid forceful coughing, avoid sneezing, use toothets or soft bristled toothbrush, gargle with PNSS or sterile water. Tips to remember nga pala sa sandostatin, possible diabetes insipidus due to removal of pituitary gland. Or this could be the tips to remember for the transsphenoidal hypophysectomy. Possible for diabetes insipidus due to the removal of pituitary gland and possible increase in intracranial pressure. That will cause brain damage. That will lead to brain trauma. That will increase the intracranial pressure. That will lead to coma. All right, we're done. So side notes tayo. Hypertonic. This is given for fluid volume excess and edema. Closure of epiphyseal plate. Sa male is 21 years old. Sa female is 18 years old. So ito yung debut births, no? Debut birthdays. Normal heart sounds is S1 and S2. Lub-dub. Kapag merong sounds after S1, that's the ventricular gallop sounds. Extra dub sounds. That's gonna be after S1 is, or after S2, kung merong sounds, additional sounds, that would be the dub sounds, ventricular gallops. Kapag after S4 naman, si S1 is the lub-lub-dub or the atrial sounds. Okay, linawin natin to ha. Si S3, yun yung ventricular. Bakit ventricular? Kasi S3, ventricular. S3, ventricular sounds. S4, atrial, 4 gallop. Sabihin mo na lang na ganun. This follows after S1. Aqueous humor, that's the fluid in the eyes. What else? Osmolality is the urine flow. Decrease in hematocrit is hemodilution. Increase in hematocrit would be, I forgot. Pero decrease in hematocrit is hemodilution. Hemoconcentration is the increase in hematocrit. Aldosterone is where the sodium goes and water follows. Aldosterone is where the sodium goes and the water follows. ADH is the water reabsorption only. ADH, that's the antidiuretic hormone, water reabsorption only. ADH, hiwalay ang water and salt. Tonsillectomy, check for bleeding. Frequent swallowing is one of the signs. All right, so that's about it. The second portion or the second part of this video will be aired soon. Hasta luego.